Welcome. Welcome, everybody. Thank you so much for joining us tonight. We have a really great webinar here. Some of my colleagues have joined us and are going to give three short talks about some very interesting topics in head and neck cancer and in endocrine, specifically thyroid oncology. There's a lot going on, and I'm hoping that you guys will find this very compelling. Just to introduce myself, I'm Caitlin McMullen. I'm a head and neck surgeon at Moffitt, and I'm an associate member of the head and neck endocrine department. It's a mouthful. Just means I'm in the middle of my career, and I work in the department that takes care of patients with head and neck cancer and with thyroid and parathyroid disease. But I just need to say a few things for housekeeping. This is a bit of a disclaimer. So the content from this evening is not meant to be medical advice, and please consult your physician if you have any specific questions. Don't rely on this information for any immediate or urgent medical needs. And if you have an emergency, please call your physician or call 911 or go to the ER, and never disregard professional medical advice or delay seeking care because of information in this webinar. So just have to say all that for our housekeeping purposes. I'm sure you understand. I'd like to pass the talk over to Dr. Otto, my partner, to talk about thyroid molecular markers. So Dr. Otto.
Thank you, Caitlin. Good evening, everyone. I'm going to be speaking about utilizing thyroid molecular markers as a way to help with surgical planning and also to improve precision in care of thyroid disease. So first, let's start with the basics. What is the thyroid and what is thyroid cancer? The thyroid is an endocrine gland that sits in the base of the neck. We all have one. The main job of the thyroid really it only has one job, and that's to produce thyroid hormone, which works throughout the body, has receptors on every cell in the body to regulate the body's metabolism. Thyroid cancers happen when abnormal cells grow in the thyroid gland. These cancers can start from a single cell, and that's typically the way a papillary thyroid cancer starts, or they can form out of previously benign tumors and become invasive, and that's the way a follicular thyroid cancer starts. Regardless of type and regardless of how it starts or how it grows, most grow very, very slowly and are highly treatable, which is the good thing about thyroid cancers. Next slide, please. So this is how we test thyroid nodules. Really, thyroid nodules are very common. Many of you have probably had an ultrasound and have been told you have a thyroid nodule. In fact, more than half of the US adults will have a thyroid nodule on ultrasound. And fortunately, most are benign, more than 90%. We use ultrasound and then biopsy when it's appropriate to help us to determine whether a nodule is benign, whether it has some funny features of the cells, making it indeterminate or atypical, whether it's suspicious for cancer or whether it's truly cancer. Next slide. So this is how we characterize nodules that have been biopsied. There's this classification system that we use for every thyroid biopsy. It's called the Bethesda system. And it allows us as the physicians to counsel the patients on what is the true risk of malignancy related to the biopsy results. So sometimes we get a pure black and white answer. The nodule is benign or it's cancer. But a lot of times we get something in the middle. It's atypical or it's suspicious for a neoplasm, which means a tumor of the thyroid gland, which could be benign or malignant, or it's actually suspicious for cancer. And you can see on the right-hand side of the screen that each of those categories carries with it a specific risk of malignancy. The most, high-risk nodules are usually classified as Bethesda 6 or malignant, and even that has about a 97% predictive rate. Next slide. So some facts about indeterminate thyroid nodules. These are the ones we really care about because these are the ones where it's hard for us to understand what necessarily to do for patients. Is it cancer, or is it risky enough to be cancer to go to surgery? Or is it something that's not risky and that we can just simply watch and observe? So with indeterminate nodules, that's the categories 3, 4, and sometimes 5. Most of these, fortunately, are benign, more than 2/3. And if we do see cancers in these intermediate groups or indeterminate groups, most of these are very low-risk cancers with a non-aggressive clinical course. So we don't want to overtreat. So it's certainly the case that we would not counsel our patients with a Bethesda 3 or an atypical thyroid biopsy to get very anxious about that and go right to surgery. Interestingly, I found this statistic, which I always think is kind of puts things in perspective. The risk of finding a life-threatening cancer in the indeterminate categories of biopsies is about equal to the risk of dying from choking on food, which we all know is quite a low risk. Next slide. So some questions that we have: how can we be more certain that surgery is needed when a biopsy is not conclusive? And how can we get better information about the extent of surgery or how much surgery, how aggressive we should be when we do go to surgery? And the answer to that is probably molecular testing. And this is the state of the art for the work of thyroid nodules as it stands today. Molecular testing is a way to look at the genes, the DNA and the RNA of the cells inside the thyroid nodule, and use that to help determine how likely is it to be cancer, and if it is cancer, how risky of a cancer is it? Fortunately, most molecular testing can be done with just a simple fine needle aspiration biopsy sample. So a tiny little needle that we put into the nodule, and the cells that we get from that usually can give us the results of molecular testing. Next slide. What can molecular testing tell us? Well, it can tell us if a cancer is likely or unlikely. Sometimes we don't get a definitive answer, which is a little frustrating, but it can tell us how likely a cancer is. If it is going to be cancer, or if it's likely to be cancer, it can also tell us what type of cancer. And that helps us to really have much better insight as to how that cancer might grow or spread. I alluded in the beginning of the talk to the differences between a papillary thyroid cancer, for instance, and a follicular thyroid cancer. We know that papillary cancers like to spread to lymph nodes. So if we're planning surgery for those papillary cancers, we oftentimes will address the lymph nodes at the time of surgery, in distinction to a follicular thyroid cancer, which almost never spreads to lymph nodes, so we don't have to worry about lymph nodes in those cases. Fortunately, the molecular testing really helps us to differentiate papillary from follicular. It also can tell us how likely a cancer is to recur. A lot of times thyroid nodule or thyroid cancers are very non-aggressive, but every once in a while we'll see one that behaves in a more aggressive fashion. And usually this correlates to the findings on molecular testing. We won't just see one mutation or two mutations, but sometimes 3, 4, 5 molecular abnormalities on the same nodule. That tells us not just cancer, but it should be more aggressive about treatment up front for those types of patients. It also can tell us what types of cancer treatments will work best, as now we have some treatments, specifically oral chemotherapy pills, that allow us to target specific molecular abnormalities or mutations that we might find on testing. Next slide. So some of the common gene mutations or fusions that we see in thyroid cancer, and these are ones that you might see if you have had the experience of having a thyroid nodule and molecular testing results. The most common one is BRAF V600E, and this one predicts papillary cancers. We know that tumors with the BRAF mutation, they're ones that are going to spread to lymph nodes. We always know that this mutation indicates papillary cancer, and so we can counsel our patients if they had a inconclusive biopsy, but we find this mutation, you've got papillary cancer, you probably need an operation to remove it, and we should also be really cautious about looking for lymph nodes in your case. We also have the luxury of knowing that there are anti-BRAF targeted chemotherapy pills that can be used for patients whose thyroid cancer has gone beyond the thyroid and has spread to other parts in the body. Then we have the RAS mutations. These are associated with follicular pattern lesions, but not always cancer. These are oftentimes benign or pre-malignant lesions, but we know they do have the propensity to convert to cancer over time. So we treat these a little bit differently, and these are the ones that almost never spread to lymph nodes. When we see a RET mutation on molecular testing, well, we can counsel our patients that this is going to be a rare type of tumor called a medullary thyroid cancer. This is one that tends to be hereditary or can be hereditary, and we have to look for other types of tumors and cancers in patients who have RET mutation. And then finally, we sometimes see a RET fusion, an NTRK fusion, or an ALK fusion. These are more rare, but these generally are papillary cancers and ones that are also able to be targeted with various chemotherapy options if needed, if the cancer spreads. Next slide. So the benefits of molecular testing in the indeterminate thyroid nodule categories in the Bethesda 3s and 4s, these generally have about a 30% chance of being cancer. So they really help us to know, is it cancer or not? And that helps us to reduce the rates of unnecessary surgery. If it's low risk and there's no molecular abnormalities, the risk of cancer goes down from that baseline 30% to something in the low single digits, and we can safely avoid surgery. Whereas if we find a molecular abnormality, BRAF or RAS or something, then we can tell our patients, yeah, you probably need surgery, and whether we need to look at lymph nodes during that operation. If the thyroid nodule has a Bethesda 5, which is suspicious for cancer, high risk of malignancy, or even 6, which is diagnostic for malignancy, we can use the molecular findings to help us understand how likely is that cancer going to be to spread or to behave poorly over time, and how likely would it be susceptible to some of our common treatment strategies like the oral chemo agents I've been talking about, or even radioactive iodine. Next slide. This is just a small illustration of a study that was done looking at the known cancer nodules, or the highly suspicious cancer nodules, with molecular testing. And it found that most of the ones that are diagnostic for cancer will have a molecular abnormality noted on molecular testing. And it really helps to risk stratify those patients with high risk molecular findings, multiple molecular findings, versus those with single molecular findings or low risk molecular findings. And if you head to the next slide, it shows that the stratification of the risk groups, the molecular risk groups, really does translate to survival. So we know that a patient who has one mutation in their nodule, like BRAF, is going to have very good survival because they're going to fall in the low intermediate risk group. Whereas those that have BRAF plus something else, like TERT, which is called out here on the slide, that survival curve is shown in orange, and that really falls off over time. So there's a definite stratification that can be gleaned from the molecular testing. Next slide. This is just a pictorial of some of the various molecular testing platforms that are available to us on the market, commercially available tests. You've probably seen or heard of any of these tests if you've had a thyroid nodule, had the experience of having a thyroid nodule biopsied and with indeterminate results. Here at Moffitt, we tend to utilize the one called ThyroSeq, which gives us both DNA and RNA testing platforms. Next slide. This is an example of some of the molecular testing reports and how things will show up on your patient portal. This is a little bit hard to read. I apologize that the writing is a little bit small. On the left-hand side of the screen is an Afirma benign. And so what they found was no gene expression abnormalities in this nodule. And so even though the original biopsy was indeterminate, the molecular findings were negative, and so we can counsel the patient on the left that they probably do not need an operation. They can just safely watch their nodule. Whereas the panel on the right shows multiple abnormalities that have an intermediate to high suspicion category, and so that patient will benefit from an operation. Next slide. Here is an example of some ThyroSeq reports. And again, on the left, we have this intermediate high risk for malignancy based on the presence of copy number alterations. So that's too many DNA copy numbers in the nodule. On the right-hand side of the screen, you see that there's 2 mutations, TERT and NRAS. That patient is highly likely to have a malignancy and should be treated as such. But again, we know that the NRAS nodules are not going to spread to lymph nodes. So we don't have to worry about looking for lymph nodes. We can instead concentrate on other sites. Next slide. So in conclusion, when should we use molecular testing? We should certainly use it if the biopsy is inconclusive and we're wondering whether the patient should go to surgery. We often use it if the patient has a very aggressive thyroid cancer and we're trying to query whether additional treatment strategies will be effective or beneficial. We oftentimes use it if a patient has recurrent thyroid cancer and can't have surgery and may need to, again, utilize alternative treatment strategies, or if we're considering targeted therapies. The benefits are improved personalized care and diagnostic accuracy, inform treatment decisions. We can tell whether we need to worry about things like lymph nodes or distant metastases, and of course, to avoid unnecessary surgery when we can. There are some limitations, as I pointed out. It may not always give us a 100% answer. Not all mutations have an approved treatment, and that makes sometimes the decision-making a little bit difficult. And of course, cost and coverage may vary from insurance company to insurance company. Next slide. And that's the end of my part of the talk. We'll move on now, and we'll take questions at the end. Thank you all.
Thank you so much, Dr. Otto. For our listeners, we encourage questions. You can drop them in the Q&A box. We're going to save them all to the end, but feel free to put them in there whenever you want, whenever they come to your mind. So we'll get to all those at the end. I know that's a part we all look forward to. Next up, we have Dr. Razavian from the Radiation Oncology Department. In head and neck, we all work very closely together, surgery, radiation, medical oncology, and we're a pretty close team. Every patient gets considered for a lot of these treatments. So I'd like to turn it over to Dr. Razavian. He's going to talk about some exciting things on the horizon for detecting head and neck cancer. So Dr. Razavian.
Great. Thanks, Dr. McMullen. So like Dr. McMullen said, I'm a radiation oncologist, so I use radiation to treat head and neck cancers as well as endocrine cancers. For today's topic, I'm talking about something that's kind of similar to what Dr. Otto was talking about, which is some molecular testing. But this is specific to patients with cancers that are caused by the human papillomavirus. So the human papillomavirus is a virus that we're all exposed to at a young age. That can live dormant in our cells for many years. And then, for people, in their 40s, 50s, 60s, or even later, result in cancers. And so this is a common cause of head and neck cancer, particularly in cancers in the oropharynx. So that's cancers of the throat. That includes places like the soft palate, the tonsil, the base of tongue. The incidence of HPV-related cancers is rising. It has been rising for the last 20 years and is thought to represent about 50% of all head and neck cancers by the year 2030. General treatment options for this type of cancer can include surgery, followed by the potential need for adjuvant therapy, such as radiation and or chemo. And then other options would include definitive chemotherapy with radiation. Generally, after we complete treatment, so if we did a treatment with radiation and chemotherapy, the kind of standard at this point is to do imaging at around 3 months after treatment. Usually that's a PET scan. And that goes along with, physical exams. And those physical exams we do regularly in the surveillance period after that 3-month imaging. But we don't routinely perform imaging after 3 months. Studies have looked at whether there is a benefit to that, and unfortunately, that doesn't help us detect cancer recurrence any sooner. Most of the time, currently, recurrences are detected either on exam or when patients come back with new symptoms. So one of the things that we as head and neck oncologists have always been wanting to better understand or better help predict is who is going to recur and when can we find that recurrence sooner rather than later, so hopefully can address things when they're small and haven't spread outside of the head and neck. Next slide. So one of the ways to do this is to look for what's called circulating tumor DNA. So essentially, as these cancer cells, they divide, they replicate, they die. And as they die, their DNA gets shed kind of into our bloodstream. And so that circulating tumor DNA that comes from the cancer cell is what we can detect through a blood-based test. There are several blood-based tests for HPV-related cancers. The most common one is NavDx through a company called Naveris. That's what we offer here at Moffitt. There's a newer one out of the University of Michigan called My HPV Score. And there's different uses for these tests. So we generally will get one at baseline. So prior to treatment, if there's an HPV-related cancer, we will get a NavDx test. And then we can actually monitor that test every couple months, just like we would with a regular follow-up, to see if there's new ctDNA in the blood. So it can help us, determine if there's a recurrence. It can help us monitor response to treatment. So usually, after treatment, your NavDx score or whatever your test score is should go to 0. And sometimes that can actually help us with the diagnosis. So oftentimes I see patients whose cancer, they've been biopsied, they know that it's cancer, but they don't exactly know if it's HPV related. Rather than doing another biopsy and putting patients through that again, we can order a NavDx test, and that can tell us if it's HPV related, which can, affect both prognosis and treatment outcomes. In terms of costs, it's another question we often get. Usually with NavDx, that is covered by Medicare Part B. So that would come as no cost to the patient. Next slide. So this is an example of what a NavDx report looks like. This is the report that both I see and you, the patient, would see. The couple of things to point out here, it's going to say what the NavDx score is at the upper left. That's panel C right there. And then I think the next most important panel is E, which is in the middle of the screen there. And that's showing the trend over time. You can do the NavDx testing at various points. I generally do it before treatment and then about 3 months after treatment is over. Some people will do it during treatment to assess treatment response. And so usually, you see the score go down during treatment. It may not be 0 just yet because, not all the cancer cells have died. And then once treatment is over, ideally the score should go to 0. So you've kind of cleared the cancer, cleared the ctDNA. And then on repeat testing, ideally it stays 0, but if the score goes back up, that's kind of a trigger for me as a physician to say, okay, well, it sounds like something might be going on. Maybe it's time to get new imaging and investigate this further. Next slide. So I wanted to give a couple examples of, how the NavDx testing might correlate with the imaging or how it provides additional information. So this is a patient of mine. On the left panel, you see both their PET scan and their pre-treatment NavDx. So this patient, you can see an enlarged lymph node there, and their NavDx score was about 2,600 after chemo radiation. You can see in the PET scan image on the right side of the screen that lymph node has gone away, and now the NavDx score has gone to 0. Next slide. This is another example. So this patient, again, treated with chemo radiation. You can see their pre-treatment PET scan on the left. Their NavDx score was 145. As an aside, I will say usually the score has been shown to vary by, how big the primary tumor is or how many lymph nodes are involved. So bigger tumors, bigger lymph nodes usually means a higher score. So this patient, their score was 145. On their post-treatment PET, which you see on the right, there was some uptake in the kind of base of their tongue, the area where that was treated. So if you just looked at the PET scan alone, you might be concerned that this patient has a recurrence or persistent disease. On exam, there was nothing, that I could appreciate. And then we got a NavDx score and their score was 0. So that makes me more confident that this image probably just represents some more resolving, radiation irritation rather than true disease persistence. Next slide. And then in this example, this is a patient who was seen in surveillance. Their NavDx score actually went up, so it went up to 673. And so that prompted me to get new imaging because on exam, I didn't notice anything new in their head and neck. And their PET scan ultimately showed a new lymph node kind of in their upper chest, which is what you see in the PET scan there. And I believe that's my last slide.
Very cool. Thank you, Dr. Razavian. I know these tests are pretty exciting and a new development for head and neck cancer patients in follow-up, and there can be a lot of uncertainty after treatment. And hopefully, we don't know for sure yet, but hopefully these can help provide some reassurance and early detection in the future. So, next up, we have Dr. Kedar Kirtane. He is also a member of our head and neck endocrine oncology department as a medical oncologist. And he is here to speak with us today about our exciting clinical trials currently going on at Moffitt. So, Dr. Kirtane, welcome.
Thank you so much for not only joining so late in the day, but we really appreciate your support. I'm happy to answer any questions that may come up. Um, what I wanted to do today in this very brief few minutes is just discuss what a clinical trial is. I'll have a list of a couple of actively accruing clinical trials, but really that's going to be a conversation with you and your physician that's taking care of you at Moffitt. But it's nice to know kind of what generally clinical trials are, why they're important to advancing cancer care, and what Moffitt has to offer with regard to really innovative options. So, a clinical trial is a research study that tests new medical treatments or procedures in people. They are important for a variety of reasons because they can determine if a new treatment is better than the existing standard of care. They can help determine if a new treatment is less harmful than existing treatments, or they can help determine if a new treatment should be approved for wider use in the general population. Clinical trials allow you to potentially access new treatments before they become widely available, and they contribute to medical advancements by helping researchers understand diseases better. What's, there's a couple of misconceptions of clinical trials. So, a lot of times when we talk about clinical trials in clinic, we're asked, well, will I get a placebo? Um, Usually the answer is no. Now, placebo trials are only ethically allowed in situations where the standard of care is really to do nothing. So, an example of this is uh, if patients have cancer that has spread to multiple areas of the body, there's no ethical way anybody would be okay with giving a placebo, right? But if it's in addition to a different treatment that is standard of care, in certain settings that could happen. But as long as the base level of standard of care is given to each patient on a clinical trial, that has to be the standard. So you're always going to get something that is clinically active, and you may get something in addition. Next slide. So there are different phases of clinical trials, and we have all three of these types of clinical trials at Moffitt. A phase one is testing a new treatment in humans. The primary outcome for a phase one study is really to test the safety, side effects, and the best dose and timing of a new treatment. So we call that early phase, where many times it's not disease specific and include a variety of different patients with different types of cancers, and really assessing safety of a particular drug. Now, usually when a clinical trial goes into the phase one setting, it has to be vetted very carefully and scrutinized heavily by the FDA, and there has to be a lot of robust preclinical data to support the use of a particular drug in a phase one study, because anything that goes to humans is heavily scrutinized before it even gets there. So I can't today just say I want to start trying something and open up a phase one trial. It has to go through a heavily vetted system in order to get there. A phase two trial is something that usually occurs after a phase one trial has been done, where you have a drug, you've determined that it's safe, you determine a dose that is reasonable in balancing side effects and efficacy, and really you want to see in a small population of patients with a particular disease or condition whether there's effectiveness. Meaning, does it help the cancer get smaller? Does it help people live longer? Is there reduction in tumor burden? And that's really the intent of a phase two study. Once you've established that in a phase two study, a phase three study compares that new treatment to the existing standard of care. So, an example of this would be something like immunotherapy. Immunotherapy for patients with metastatic head and neck cancers was approved as a first line treatment for patients in 2019. Now, a lot of studies are determining, well, okay, what if we compare immunotherapy, which is the standard of care, versus immunotherapy plus a different drug that may help immunotherapy work better? And so this phase three studies, large scale, really involve hundreds of patients, usually across multiple sites, sometimes across multiple countries, in order to determine whether that is better, the same, or worse than the current standard of care. Next slide. Our current standard of care kind of depends on what stage of disease someone has. someone with locally advanced disease, there's really two major paradigms for treatment. One is radiation therapy plus chemotherapy or targeted therapy for about 6 to 7 weeks. The other sort of major treatment paradigm is surgery, followed by radiation plus or minus chemotherapy, depending on what high risk or low risk features there are found on surgical pathology. For patients with metastatic disease, meaning if someone has had a head and neck cancer start somewhere and spread outside of the head and neck, it's not usually something that we can cure. And so, as I mentioned, it was established based on a phase 3 study of over 880 patients that immunotherapy plus or minus chemotherapy was better than just getting chemotherapy alone. And so that is really our standard of care. Next slide. Chemotherapy, most people have some concept of, it's been around for decades. Chemotherapy basically stops tumor growth or kills cancer cells that are actively dividing. Um, the reality is that that is not specific to cancer cells. And while the presumption is that cancer cells actively divide at a higher rate than most of your normal body cells, there are very fast growing cells in your body that are normal. And that would be things like the GI tract or things that help your hair grow. And that's why many times cancer treatments that involve chemotherapy can cause side effects that affect those cells kind of as a off-target effect. So although it tries to be really selective in treating disease, unfortunately it can have side effects to your normal body cells. But really the intent is to stop cells that are actively dividing. Next slide. Targeted therapy is something Dr. Otto mentioned, is sort of a new in vogue treatment over the last several years. And these are treatments that you have found a particular mutation in a cancer cell that we think drives the growth of the cancer cells, and we block that. The classic example that I believe Dr. Otto gave was BRAF, which is a particular mutation found in many thyroid cancer cells, and for whom we have treatments that you actually just block that mutation and make the cancer smaller because it can no longer grow as a result of that. Are listed at the top of that slide a number of different types of targeted therapies, some of which are already approved for use for patients with head and neck cancers, but that's really different than chemotherapy. So while chemotherapy, as I mentioned, works on cells that are actively dividing, this really targets it to particular cells that have mutations that grow the tumor. Now, that doesn't mean they're not without their side effects. Of course, they can have side effects, but it tends to be a little bit more targeted, hopefully, compared to chemotherapy. Next slide. Immunotherapy is kind of the new kid on the block. They're calling it the fourth pillar of cancer treatment. There was surgery, there is surgery, there's radiation, there's chemotherapy, and now really over the last decade, immunotherapy has become a really prominent therapy for patients with cancer. I know the graphic isn't the best right now, but I'll explain immunotherapy the way I explain it to my patients. Some of you may have heard this explanation. Cancer cells don't look like they're like your normal cells, but what they've done is they figured out a way to disguise themselves against your immune system. In contrast, if you were to get a virus or a bacteria into your body, so say you get something like the common cold virus into your body, you have fevers, you have chills, you may have a cough, a cold, a sneeze, and really those symptoms are manifestations of your body's own immune system surveying your body and saying, you know what, this virus should not be here, I'm going to go and attack. It does that really well with a lot of viruses and bacteria. It doesn't do it that well with cancer cells, and that's why cancers can grow uncontrollably. And one of the reasons it does that is because cancer cells are smart, and what they've done is they've cloaked themselves in a disguise, and they fool your immune system into thinking that it is okay to be there and it doesn't need to do anything. So what new drugs called immunotherapies do is really they try to unfool your immune system and kind of block certain things that fool it, allowing thereby your immune system to attack those cancer cells. So it's really a drug that uncloaks that disguise and says, hey, immune system, go and attack these things that should not be here. Next slide. Um, Immunotherapy is really great in some ways because it's much more targeted than chemo, a little bit more systemic in some ways than targeted therapy. But it only tends to work about 20% of the time. So we have a lot of clinical trials for patients either for whom immunotherapy has failed or in some ways trying to augment the efficacy of immunotherapy. I won't go over all these trials, but we have trials that range from therapeutic cancer vaccines. We have drugs that add to immunotherapy, targeted therapies. Um, and we have even other types of treatments that work on the cell cycle that really are more they're kind of more advanced therapies that still work on the cell cycle but are more advanced than chemotherapies. Next slide. So as you can see, we have a lot of clinical trials, and that's kind of one of the nice things of Moffitt is that we are not really just trying to follow standard of care, but we are trying to actively define it. And a lot of us have participated in clinical trials that have subsequently become standard of cares that are followed nationally and internationally. We have meetings, all the time throughout the years in assessing data in clinical trials and really trying to figure this out. Now, whether a clinical trial is right for you is really a discussion you should have with your doctor. And while we have a plethora of clinical trials at Moffitt, the decision to enter into one is a complex and nuanced one, and that's something that you and your physician should really discuss. The first slide was patients with metastatic cancer. This slide is patients with locally advanced head and neck cancers. So we really have a variety of different trials for a variety of different stages and types of cancers. Next slide. And this is for patients who have had their cancer go away and then unfortunately come back as well. So really all kind of stages of trials. Next slide. I'll end with just highlighting one new concept that we have that is becoming kind of more in vogue nationally. And this is something called neoadjuvant therapy. Neoadjuvant therapy just refers to giving a treatment as a first step to shrink a tumor before the main treatment. An example of this is that one of the standard of cares for patients with oral cavity or tongue cancers is usually surgery. Um, this trial that we have gives a combination of an immunotherapy and a targeted therapy before surgery to try to make sure that the cancer is more controlled. In other words, many times the cancer under the microscope after surgery can show a lot of high-risk pathologic features that obligate the recommendation for more additional therapy. In this case, we're given something before it to try to shrink the tumor, to try to make the surgery a little bit easier, and then we follow those patients up as we would normally, a standard of care. Now, this idea of neoadjuvant therapy is not a new one. It's already the standard of care for many types of breast cancers, some bladder cancers, some esophageal and gastric cancers, and there's actually some preliminary data that it may be really effective for head and neck cancers, and that's what we're basing this study on, is basically trying to combine that immunotherapy and targeted therapy to see if it makes surgical outcomes better. Next slide. And that's all I have. So I'm open to any questions about just clinical trials in general or anything you all have.
Thank you so much, Dr. Kirtane. As a surgeon, I'm particularly excited about some of these neoadjuvant trials because in head and neck cancer, as many of you on the chat may know or have experienced, the cancer itself and the surgeries can be very hard on physical appearance, talking, eating, and there's some hope with these medications that we can potentially shrink down the amount of tissue that needs to get treated or removed and improve the cancer control rates down the road. So we're very, very hopeful about it. It's a very exciting new horizon for head and neck cancers right now, and we're very proud to be a part of some of the early trials investigating this here at Moffitt. So thank you so much for our speakers. Please turn on your cameras again if you don't mind, because we have some questions from our participants. Thank you so much for the folks who submitted some questions, and please feel free, anyone, to submit. We've got some time to answer them. So let's start with Phoebe Morgan. Thank you. We have first question, which is, what are the signs of cancer? Dr. Razavian, maybe, do you want to talk a little bit about the signs of head and neck cancer?
Sure. So common things my patients will present with, and it's going to vary depending on, where the cancer started and where it has spread to. But common things would be things like throat pain. It can be pain with swallowing, voice change. Several people, especially with HPV-related cancers, may notice new masses in the neck. That's what kind of prompts them to go see a physician. So those are often common things that patients will tell me kind of prompted them to get a further workup.
Yeah, for sure. We see that a lot too. Some of the things that we see on the surgery side would be like a tongue sore that doesn't go away, especially after 2 weeks or so, continues to grow. Sores on the gums, creating loose teeth that doesn't go away. Ear pain that can't really be explained by an ear infection. Mostly symptoms of particularly pain in the head and neck that doesn't really go away like you would expect a cold to go away after a couple of weeks. So if you experience anything like that, definitely get it checked out by your physician. All right, so let's see what we have next. Okay. All right, next up, we have a question about TSH and oh, okay. So Dr. Otto, if you don't mind, this question I'll direct to you. So I've had normal TSH levels and goiters that are looked at every 2 years with ultrasound. No real changes are noticed. So what should I watch for, and would a biopsy be something to look at molecular biomarkers? So sounds like, what are the indications to do a biopsy and check molecular markers in a goiter that's been there for a while?
Great question. We use ultrasound as the main screening test to determine whether any given thyroid nodule deserves further workup with biopsy. And so there's just like I mentioned in my talk about the scoring system, the Bethesda system for biopsies, we also have a scoring system for ultrasound. There are several different ones. The most common one that we utilize is something called the Thyroid system, but it essentially allows us to assign a risk score to any nodule. As I mentioned, nodules are exceedingly common and almost always benign. And so certainly every last thyroid nodule does not need further workup with biopsy. But if it has a high TIRAD score and a very suspicious appearance on ultrasound, those are the ones that we generally target for biopsy when they're seen. It's based on the TIRAD score and also the size of the nodule. So a period of observation or surveillance like what you're describing, having an ultrasound every couple of years is a very, very acceptable and standard of care practice for TIRADs, low risk, and smaller thyroid nodules.
Thank you, Dr. Otto. And it sounds like, we don't send those molecular genetic markers unless that biopsy is really not conclusive. So if you had a goiter biopsy and it came back as benign, we wouldn't really send off those molecular tests. They're not well studied in benign tumors, and it wouldn't help guide us one way or the other. Is that right, Dr. Otto?
Absolutely, yeah. So without a biopsy, there would be no reason to get molecular studies, and there's certainly no reason to get molecular studies if a biopsy is not indicated. So absolutely right, and certainly not with benign. We use the molecular markers for those that are indeterminate or even suspicious for cancer, and we're trying to decide really what is the risk of cancer and how much treatment does that patient need.
Yeah, ultrasound's been around a long time and it seems low tech, but it's the best test for thyroid and thyroid nodules. All right, so next question is Dr. Razavian, this is for you. So I know there's always a lot of concerns about patients and radiation side effects. So have there been improvements in the last 15 years that limit collateral damage to surrounding areas from radiation treatment for head and neck cancer?
Yeah, this is a great question. There definitely have been significant improvements, especially in the last 15 years. The way that we used to treat head and neck cancers 20, 30 years ago was much more simplistic compared to what we do today. Back in the day, you'd essentially have like 1, 2, maybe 3 radiation beams coming at you. Now we have a technology called intensity modulated radiation therapy. That's pretty much the standard of care for all head and neck cancers. Using this technology, we're able to specifically spare out parts of the head and neck that we're really trying to limit radiation dose to. So things like the salivary glands, things like, the voice box, if it's not involved, we're trying to spare the radiation dose as much as possible. I think the next thing on the horizon, and Moffitt is kind of just getting into this as well, is proton therapy. So that's a bit different than the current kind of conventional high energy x-rays that we offer here at Moffitt. Proton therapy is essentially we make these heavy particles that's what we use to treat the cancer. And so with this proton therapy, the kind of scatter radiation or the spread of the radiation dose is much more limited compared to even IMRT. And so the thought is that, the use of proton therapy in head and neck cancer could potentially, really improve the side effect profile for patients. And so if any of you guys have heard of Spiros, that's kind of the new area that, we're opening a clinic in. And so hopefully about this time next year, we should have a proton therapy unit to treat patients with protons.
Thank you so much, Dr. Razavian. That was awesome. I really appreciate it. Okay, let's keep going. Lots of great questions about thyroid cancer. Dr. Otto, are there targeted genes that can indicate thyroid cancer recurrence after surgery, a more effective replacement for thyroid globulin? That's very interesting.
It's a good question, and I think we're not quite ready for prime time there. So just like Dr. Razavian mentioned with the NAVDX, the circulating tumor DNA for head and neck cancers, there is some work looking at circulating BRAF, for instance. It's not widely utilized in clinical practice and certainly would only apply to those tumors that we know have a BRAF driver to begin with. So actually thyroid globulin is our main strategy right now with the addition of imaging. So unlike Dr. Razavian mentioned with head and neck cancer where we don't do imaging after 3 months, with thyroid cancer, we absolutely do imaging after 3 months, and we continue to do imaging periodically over time, often just ultrasound alone with the addition of the thyroid globulin, which is the tumor marker for thyroid cancer. And then that expands to things like CAT scans and PET scans in select cases when they're really necessary. So thyroid globulin is really the kind of current state of the art with imaging.
Awesome. Thank you, Dr. Otto. That's very helpful. Great questions. All right. What are the major causes of thyroid cancer? Peppering you with questions, Dr. Otto.
All right, I can take this one again. So major causes. Well, so the classically recognized cause of thyroid cancer is prior radiation exposure. But I will say that the vast majority of patients who get thyroid cancers do not have that history. So that's really the only known recognized cause at this point in time. There are rare thyroid cancers, as I mentioned in my talk, things like medullary thyroid cancer that may have a genetic predisposition. But most thyroid cancer, the vast majority of thyroid cancer, occurs for reasons that we don't understand. We understand the molecular drivers and the DNA and RNA alterations that go into making those tumors start, but we don't know why patients get those DNA abnormalities.
Okay, very helpful. Thank you. All right, let's keep going. Oh, this is a good question. I don't know if we have any AI experts on our panel tonight, Dr. Kirtane. I don't know about you or Dr. Razavian, but have you started using AI in your research or do you plan to do so? Any of our panelists want to comment on that?
I can take that. Yeah, it's still new relatively, the technology, but it is starting to become really involved with oncology clinical research. I think there's different areas where, while Moffitt has a AI working group at their institution, so there's a group of people that are working on answering that exact question in a meaningful way that'll help patients live longer and feel better. But I think the best use cases of AI are probably detection and diagnosis. So taking large data sets from radiographs, so X-rays, CT scans, and even using digitized pathology to look for things that the human eye may not be able to see. But it's going to require taking a large set of data and figuring out retrospectively who has a cancer, who doesn't, and what their risk factors are. I think in the future, it's probably going to help with treatment personalization, so help provide clinical decision support and individualized therapy selection. From an oncology clinical trials standpoint, I think it can really help with drug discovery, so target identification, drug design, response prediction, so using large data sets to really predict who is more likely to have a good response to a particular drug. To the answer to your question, I think there isn't a standardized way of using it. I think Moffitt's already thinking about this, so there's a group that's already working on figuring out ways to implement AI in the clinic. and preclinical data, clinical data, and then post-treatment data. So it's rapidly expanding and it offers the potential for really personalized care. But I think the future will be really interesting. I know I use it in my day-to-day life just with, AI summarizes your emails and it's kind of nice in some ways, but I'm sure others have also some experience with it.
Yeah, I'm looking forward to implementing that on the clinical side to help, sort through complicated medical records, summarize them, and help us care for patients in a more efficient way and know them very well when they're coming in and not having too many records that you can't get and having everything kind of easily accessible. I know that already exists for AI technology, so hopefully we can have that in the clinic soon. All right, last question here. So, Dr. Kirtane, I think I'll give this to you. So, what treatments do you think, especially with the clinical trials we've been talking about, will become standard of care in the future? Will TIL be an option?
Yeah, I mean, I think there's I'm going to give you a little bit longer answer. So there is I view clinical advancement in two ways. There's incremental benefit and then there's revolutionary benefit, right? So I think in the short term, over the next, 2 to 3 years, what you're probably going to see is an innovation in standard of care, at least for patients with metastatic disease, which is a little bit more my focus, is combination therapies. So immunotherapy plus a something else that augments the efficacy of immunotherapy or helps immunotherapy work better. I think you're going to probably see that in the next year or two. We have a couple of major meetings in the next couple of months that are going to highlight some of this data that I think may prove that to be true, although I don't know that for with 100% certainty. So I think that's going to be the first step you'll see. Um, the second step is something more revolutionary. I'm biased. I work with our cell therapies group here, so it's still a little bit out there. But TIL is something called tumor infiltrating lymphocytes, which is basically a therapy where you get a tumor specimen from someone's cancer, and if you look under the microscope, you're actually going to see immune cells already there. Now, they figured out a way to get there, but they haven't been strong enough to really cause a regression of disease. So someone in the 1980s, actually a very long time ago, thought to themselves, well, if the immune cells are there, why don't we just take them out from the tumor, recharge them in some way, and give them back to the patient? So one of our Moffitt surgeons actually led a clinical trial for melanoma with TIL that is now FDA approved, and we treat a really high volume of those patients at Moffitt. We're trying that in lung cancer, in head and neck cancer, in colorectal cancer. The data is preliminary, but I don't know. I think that's more of a long-term goal. And I say that more revolutionary because I think some of the incremental benefits can help people live longer and feel better. But even with immunotherapy, which is approved a couple years ago, cures are rare. We don't talk about cures when we talk about that with patients. We usually say helps you live longer and hopefully feel better. But on cures are probably on the order of 1 to 2%. I think we've set a low bar for what we define as success and somewhat in some levels. And so I think things like cell therapy, where you're really figuring out ways to recharge the overall immune system, hopefully can afford cures to patients who were not cured previously. So I think TIL could become a standard of care, but that's probably years away. It's just going to depend on how some of these trials go. Sorry, there's a long way of answering your question, but I think what you're going to see in the short term is some combination therapies, and then later on, hopefully, you'll see new drugs that are better than immunotherapy.
I think on the surgery side, what's going to become standard of care is the neoadjuvant. So giving drugs before surgery. So, and that could be pretty soon. All right. So we do have a couple more questions, but I do want to introduce David Curry, a critical member of our team at Moffitt here, and we only have a few minutes left, so I don't want to miss this opportunity. So, David, if you don't mind saying hello.
Yeah, absolutely, Dr. McMullen. Thanks so much to you, Dr. Otto, Dr. Kirtane, Dr. Razavian. It's another great night in our webinars discovery series, and so we appreciate all of you volunteering your time to make these presentations. Very insightful. They're going to be very helpful. I also want to thank my foundation colleagues, Brio Humphreys and Stacy Price. They're kind of working behind the scenes and making sure everything goes smoothly tonight. but especially everybody who attended. There's so many things that you could have done tonight, but you chose to be with us. And so I just want you to know how much we really appreciate you giving us your time and joining into the webinar tonight. The reality is Dr. Kirtane was talking about clinical trials and all of that. None of that happens without translational, what's the word I'm looking for? I just lost it. But we need to do translational research in order to lead us to these clinical trials, phase 1, phase 2, phase 3. And that's where some of our attendees might come in. If you have any idea that you want to support through philanthropy, some of these research initiatives that are happening in the head and neck space, thyroid space, please contact me at your convenience. The reality is that your support just might be the catalyst for a cure. And so thanks for being here tonight. I think we may have another question or two. And if we don't get all of them answered, we will reach out to the presenters. We'll get answers and we'll get them back to you. So thanks again for being here. And now back to Dr. McMullen to close us out.
Thank you so much, David. Very grateful for that. It's true that patients and family members do support some of our research efforts, even some projects that I'm doing. So we're so grateful for your attendance tonight and for listening to all the great things we have going on. I think we have time for another question or two. Let's see. Thank you for all your great presentations. To any of you, can you tell me why you chose to work at Moffitt and what makes it different than other places? I'm happy to take that question. I've been at Moffitt for about 7.5 years now. I can't believe it, but I chose Moffitt over other places because it's a dedicated cancer center. I wanted to focus my career entirely on taking care of patients with head and neck and thyroid cancers. And in a place like Moffitt, you work so closely with people from other disciplines. You're not just in a surgery office or in another building in your radiation office or in another building in your oncology office. We're all working together in the exact same physical space. We all work together every single day and communicate directly about patients very frequently. That helps us expedite patients' care. It helps us understand everybody's role in taking care of complicated patients with head and neck cancer. So I'm really grateful for the collaboration and the communication working at Moffitt affords me when taking care of my patients. So I don't know if anyone else has thoughts about why you work at Moffitt.
I agree with that, Dr. McMullen. I think that in addition to just being in the same physical space, we can actually, and often do, set up clinics where we see patients together. So for instance, myself and Dr. Razavian or myself and Dr. Kirtane, or all three of us can go in and see a patient with a thyroid cancer who might need surgery and radiation and possibly systemic therapy afterward to give them the entire gamut of the care from start to finish in one appointment. And that really helps to facilitate the patient's understanding of the longevity and the long-term nature of the cancer care.
Dr. Kirtane, Dr. Razavian, anything you want to add about your experience?
I can just say that I came from Seattle, so really the other side of the country. And I'm from Florida originally. And when I told my mentors I kind of want to go home. They said the only place they would work in Florida is Moffitt. And so they knew our chair, Dr. Chung, they knew a lot of people here already. So it's kind of comforting that really all the way across the continental United States, Moffitt still has that reputation and name. And it's really panned out for the last nearly 7 years for me here.
Yep, that's for sure. Dr. Razavian, any thoughts? You're the newest member of our group.
Yes, I'm the newest one, and I really echo what everyone else has already said. I've been at Moffitt for about 8 months now, and one of the main things I was looking for, was a place where you could really excel at being a physician that treats head and neck cancer. And, that's the sense that I got when I interviewed here, and that's the current sense that I have working here. I think the other thing I really like about Moffitt is just like the level that it'll go to support patients. I feel like, Moffitt as an institution does a great job of supporting patients through the, process of treatment and survivorship and things like that.
Yep, completely agree. It's a great place to be able to do your job and what you're passionate about. We got 1 minute left. So last question, nutrition support to help stay cancer free, especially after thyroid surgery. Any of our team members have thoughts about nutrition or diet after surgery or treatment for cancer?
I can talk a little bit about while there's no specific diet plan that helps someone stay cancer free from thyroid cancer, understanding how your thyroid hormone replacement interplays with your diet is really important. And we all know that the thyroid hormone replacement pill, the levothyroxine or the Synthroid that you take after thyroid surgery, is equally as important as all of the other things we do at suppressing the growth of thyroid cancer following surgery. And that pill is best absorbed completely separate from food. And so taking that on an empty stomach is extremely important. Separated by food by at least from food by at least 30 minutes, and then many hours if it's vitamins or calcium containing pills. So while there's not a specific diet, there are some dietary things that we talk to patients about so that they can get the best benefit out of the surgery and the follow-up care that they have for thyroid cancer.
I know with head and neck cancer, we really don't want people to go on any extreme diets because you can lose weight and with the treatment itself. So we try to keep people's calories up whichever way they can. Dr. Razavian's nodding.
Yeah, very true.
All right. We have one last question, but we are out of time. I'm gonna work with David and Brielle to get a response to our last question offline, but it is 7:01, so we're out of time tonight. I am so grateful to all of our attendees. Thank you for listening to all of the great things we have going on here at Moffitt. Thank you to Stacy and Brielle and David for helping to organize this evening. And especially thank you to our panelists for taking time this evening to join our discussion. All right. That's it for tonight, and we'll see you next time. Thank you.